address this morning. The keynote address is none other than Professor KUMAR sir, and he actually needs no introduction, but I'll just give him a one-line introduction. That is, he is the only Padma Shri that we have in the glaucoma world in India. Over to you, sir. All yours.
What a wonderful course. It was indeed really heartwarming. And Prasanna's enthusiasm is really, it seeps into you. And really, I learnt a couple of things here. It was really, the entire course was so beautifully
Thank you,
chiseled
sir.
out.
And we always learn from you at every talk that you give.
Okay, so the aim of this talk primarily is to be able to instill in youngsters the idea to try and think out of the box. Actually, Arijit stole my line from there. He already said this word. But the hard fact is that we are always looking at one thing and we are always trying to do things by the rote or whatever has been taught to us. So, okay, so basically we all know what is there in glaucoma. The commonest thing obviously that all of us do is a peripheral iridotomy. And why is it we are doing it? Basically because there is an iris Bombay. So we do it in acute ACG, PAC, fellow eye, and all the secondary glaucomas. However, the fact that it has the ZAP trial and the Singapore trial have clearly shown to us that maybe we are overdoing it. And the hard fact is that especially in PACS. What is the definition of PACS? If you cannot see posterior trabecular meshwork for around 180 to 270 degrees, the moment you indent, the fluid goes on either side and it opens up completely. Now this is a PACS. So many people will come to you, and especially ladies, 40-year-old, they have come for a refraction, and then you will say, oh, this is this thing, I will do an iridotomy. And in the end, what happens, you know, all our eyes are pigmented and the pigment will go and settle in the periphery and the pressure will rise. So what I'm trying to tell you is that don't take iridotomies lightly at all. So our own concept has changed. We used to do so many iridotomies previously, but we have now gone back a little bit. We are not so hard up on that. So you have a gonioscopically PACS. Check, is there a family history of angle closure? If it's a one-eyed patient, if it is going to need repeated dilatation, is there a history of IOP elevations? Is there something wrong in the field or the disc? Like gentleman said, yes, disc is the crux. You have to know how to read the disc. And obviously, if it's a fellow eye, fellow of an acute or a chronic ACG, obviously we are going to do. You can do a prone darkroom test, or the patient is likely to be lost to follow-up. So in these situations, yes, go ahead and do a PI in a PACS. Otherwise, please try and follow up these patients. Now, some of these patients are very, very jittery. So you tell them, okay, you carry this bottle of pilocarpine and a patta of Dimox with you so that if anything happens before you reach a doctor, you can always take that. So that will calm their nerves to a little bit. But yes, be careful. So, what about chronic angle closure? So many people say, sir, if the angle is already closed, what am I going to do over there? Very correctly said. So, unless you can find that there are some areas of open angle over there and there is a little bit of iris Bombay, you can then do an iridotomy. Otherwise, it will worsen the situation further. Again, please remember, I will be telling what exactly is the role of gonioplasty, but this was a paper with N.N. Sood, sir. And so what we found was that a couple of patients who were chronic angle closure controlled on peripheral iridotomy and medications, but not fully. They are one-eyed patients. They don't want to get operated. You don't want to operate them. Add on a gonioplasty. Do a 360-degree gonioplasty, and what you will find is many of these patients will be controlled for a long, long time. So people keep asking how much energy to use. If you have a very fresh laser, obviously even 5 millijoules may be good enough. If you have an old laser, maybe 10 millijoules may not be good enough. The aim is to finish the thing in 3 to 4 shots. If you do it in one shot, you are likely to subluxate the lens sometimes. But if you want to do it in very slow this thing, there will be just chipping of the this thing iris, and there will be all pigment in the anterior chamber, and you can't do anything then. So be careful about what you are doing. And if it's a very tough iridotomy that happens all the time with us, first of all, be careful. Never tell any patient that I'll just finish it in 2 minutes. The day you say this, that day you'll know you'll not be able to complete it at all. So please tell them it's not an easy procedure, but yes, we'll try and do our best. So you can put the gonioplasty spots. So what are these gonioplasty spots? They are larger size spots which are just stretching out the iris. So if you put it all around over here, it will create a drumhead pattern, so that everything is stretched, and then you put an iridotomy shot in the center, and the thing will immediately open up. So that is one of the tricks. Now another thing over here is that if you are lucky enough to have an argon with you along with the YAG laser, then what you can do is you can actually put a laser on either side, one spot on either side, and then suddenly you see that the whole thing will open up to a greater extent. So if you have done, you don't want to put a shot through that iridotomy and create a problem over there. Now once we actually put a shot, the patient moved and the shot went onto the edge and the iridotomy got reduced. So this is how you keep thinking now, you know. So we have for 70 years the iridotomy is known, and the dysphotopsias, ghost images, etc. are known for last 70 years. And till today, nobody has given us a cure for what to do in this kind of a situation. So luckily or unluckily, a patient came to me, and we have all had these patients. And he said, sir, I am in big trouble. I am a photographer. I can't do anything. The light is coming in as if there's all the time these images are there. I can't do even my job, do anything. So I said, what to do with that? So I put a tinted contact lens, gave him dark glasses, nothing helped. And then this is how this procedure was born. So what happened over here was, like I told you, that day I was stretching this, and instead a shot came over here, and this whole thing actually became narrower. And then suddenly I thought back, all right, let me try this. So once you put 2 shots over here of around 200 millijoules with 0.3 watts power, the iridotomy stretches out like this and becomes narrower. So this is the first time that we really thought about this, and now this is published. So you can see over here a wide iridotomy. These are the 2 spots that you can see over here, and they suddenly become narrow. And this we published, and this is the same thing in the OCT, anterior segment OCT, that you can see. And this is, but be very careful, don't go near the pupil, otherwise the pupil will get enlarged over here, because it's basically stretching whatever it can stretch. So be careful about that. This just got published in the current IGO this thing, March this thing. Okay, there was another new mechanism. So this patient, again, this time our retina surgeon, who are so benevolent to us, giving so many glaucomas to us. So this, what happened was, there is a complete, as you can see over here, there is a pass formation over here. It's not a permanent pass, but a temporary pass, because the fluid is trapped over there. And I said, okay, take out the oil. And they said, no, sir, it is just very fresh and it will be redetached. And the one-eyed patient, a glaucoma patient, will be in big trouble. So please, please, please do an iridotomy. You can't do an iridotomy here. There's an oil, and nothing will happen if you do an iridotomy here. You have to do an iridotomy at this thin place where the fluid is trapped. So I said, this is not possible. He said, no, sir, we have to do it. So we went in. So what I did was, with 2 millijoules, I just pushed back the iris a little bit, and then the moment it was pushed back, we put bigger spots over there of 6 millijoules, and the iridotomy was completed. This thing was released, and everything was back to normal. Again, this was published as a new mechanism for silicone oil induced glaucoma. So that's what I'm thinking, that you have to think of new things. Iridoplasty is something that each one of you can do very, very easily without any problems. The idea is less power, larger size spot which stretches out the iris. That is the basic purpose of all the things that I showed to you. So these are just various techniques of doing it. But what I wanted to, so obviously classically it is known for plateau iris, but what I want to show you is this, an acute angle closure. And I keep getting phone calls from my friends and even this, so this professor from AIMS calls me and says, sir, I'm in big trouble, one-eyed patient, and a situation like this has arrived through the corneal edema, I cannot do an iridotomy, what to do? And everything we have given, including mannitol, Dimox, should I go in and operate? But I'm so scared there'll be a big problem. So I said, try an iridoplasty. And he said, are you joking? I said, just do it. And he says, how will they penetrate? But the red laser, the diode, or the green laser also penetrates easily even through edema. And then half an hour later, his phone call comes back and says, sir, it is a miracle. So please, everybody having acute angle closure cases, remember, if it is not being controlled by medication, you cannot do an iridotomy, please try it on iridoplasty. It works beautifully. And even ACG block at the lens, when you are going to do the lens at a later time, then obviously you can try this out for time being. Same with topimeride induced. So all these small things will help you out. I think we are out of time, so thank you very much for a wonderful hearing.
Thank you very much, sir, for that very, very illuminating talk. And I'd like to ask you just one single question. If you were to give a one-word answer to which is the best site to do a primary iridotomy,
yeah. So
what would that be?
The answer is that wherever you can easily do it. So wherever, so it could be inferior anywhere, but if you have a crypt, if the chamber is deeper over there and you are sure, please go ahead at that side.
Yes, that's exactly what I wanted to emphasize on, because we have notions that you should do it superiorly, you should not do it inferiorly, but these are all actually the second step. The first thing is that where you can actually use the least amount of laser, have a proper crypt, the iris is well stretched, that's the place that you should do an iridotomy. Any other questions? Yes, please.
Sir, one question, one quick question. Sir, role of clear lens extraction in the ACG?
Clear lens extraction role in angle closure.
Only in one case, if you are going to do a trabeculectomy and the chamber is extremely shallow and you will get into more trouble, in that case we will permit you to do a clear lens extraction. Otherwise, we in India, if I am right, Chandrima, we are not keen on clear lens extractions.
Okay.